This conference will now be recorded.
Good morning, everybody. I think we'll get started, folks. If you want to grab your seat, welcome. Today, our guest, Dr. Eugene Shapiro from Yale and New Haven, Connecticut, is going to be talking about Lyme disease. I don't know if any of you heard Brian Goldman's White Coat Black Arts on the weekend. He talked about Lyme disease and people who feel afflicted by chronic Lyme disease, whatever that means. And it was a very interesting discussion with different patients and physicians who are on different sides of the equation. I think whatever does cause, or whatever is the reason behind chronic Lyme disease, I think those people deserve good science, and they also deserve compassion as well. They're looking for something, and but it's our duty as clinicians and scientists to try to clarify the waters when they're muddy and know what questions have to be answered, I think. Dr. Shapiro is a graduate from med school from the University of California in San Francisco and did his pediatric and infectious disease training at Yale, at Children's Hospital in Pittsburgh, and did his epidemiology at Yale and started on faculty at Yale, where he's now a professor in 1983. He's currently professor of pediatrics epidemiology and investigative medicine there and vice chair for research in the Department of Pediatrics. He's also deputy director of Yale's PhD program in investigative medicine and co-director of education and director of child health research for Yale Center for Clinical Investigation. Dr. Shapiro has over 250 publications, mostly related to vaccines. He's been a consultant for the WHO and chair of the advisory group for the epidemiology branch of NIH, and also a special advisor to the FDA's Vaccine Advisory Committee in the States. He's been honored in 2014 with the Stanley Plotkin Lectureship in Vaccinology Award for Career Achievement for Research in Vaccinology, and also in 2017, he received the Pediatric Diseases Society Distinguished Physician Award for an extensive and distinguished career in pediatric infectious diseases. So without further ado, Dr. Shapiro, we welcome you to Nova Scotia. He's heading to the best part after here to Cape Breton, I understand, to see the sights. Go Cape Breton. And Dr. Shapiro, the floor is yours.
Thanks very much. It's a pleasure to be here. Here's my disclosures. I've received royalties from Up to Date, a one-time honorarium from Sanofi for a conference about Lyme vaccine, and I've served as an expert witness. So Lyme disease is caused by the Spirochetes Borrelia burgdorferi. It's transmitted by Ixodes scapularis, the deer tick, and other Ixodes species. The pathogenesis, ecology, and epidemiology are well described. Antimicrobial treatment is very effective. Complications are rare. That's really all you need to know about Lyme disease. Thank you. All right, well, I'm going to talk a little about Lyme disease, a fair bit about diagnostic testing. I'm going to talk about advances in treatment, a surgical procedure, tick bites, and not Lyme disease and medically unexplained symptoms, and probably won't have time to talk about co-infections much. So this shows you the incidence of Lyme disease in Canada. A little hard to see this, but you can see over that it's increasing a little bit. These are the different provinces, and Nova Scotia has the highest incidence, which is comparable to over here are the incidences in neighboring states in the U.S. So much of the Nova Scotia has actually the highest incidence. This is per 100,000 population, and this slide shows the location. The upper is how often they were able to identify Ixodes scapularis deer ticks when they did drags, the proportion of them. The darker red means 80 to 90% of the 80 to 100% of the time when they you drag a cloth through a field and you look to see if there are ticks on it, and you can see that. And then the lower part here is the incidence, and you can see in Nova Scotia that much of the disease is in the Halifax and southern area, And there's lots of, the bottom line is there are plenty of deer ticks in Nova Scotia. All right, so the clinical manifestations of Lyme disease can be broken down into early disease, which is primarily single erythema migrans. It's called erythema migrans because it starts as an erythematous mark, a macule at the site of the tick bite, and expands or migrates. It gets bigger. Disseminated, and that's about 2/3 of disease. Disseminated disease includes early disseminated disease, multiple erythema migrans, neuritis, carditis, meningitis, and late disseminated disease, or just late disease, which is primarily arthritis. So 80 to 90%, maybe even more, of patients with Lyme disease have the characteristic rash erythema migrans. Of those who have erythema migrans, about 3/4 is localized disease, and about 1/4 is multiple erythema migrans. And this is a picture of the classic target lesion erythema migrans rash. You can see the central clearing, but in fact, this is rare. Only about 1/3 of all erythema migrans looks like this. It's much more common to have something that looks like this. This is on somebody's back, and you can see it's uniformly erythematous. There really isn't central clearing, and it's not perfectly round either. And this is about 2/3 of erythema migrans look more like this. The other thing is, if you're not sure if something is erythema migrans, there's no emergency. It's only erythema. It's only Lyme disease. It's not HIV. So you can watch it for, especially if they're asymptomatic. If it's gone in 2 or 3 days, wasn't erythema migrans. Erythema migrans will persist for usually a minimum of a couple of weeks and will continue to enlarge. Here's somebody with multiple erythema migrans. This lesion here is the primary lesion, probably. It's larger. You don't always see that. And these are multiple other lesions. And all this means is that the spirochete gets into the blood and disseminates, and the favorite place for it to land is other sites in the skin. If you biopsy these, you could identify the organism in all of those. So as I said, about 1/4 of the clinical manifestations are early disseminated disease, and most of it is multiple erythema migrans. About 5%, and this is in the US. In Europe, it's a little different because there are different strains. There's more neurologic disease, but it's about 5% are cranial nerve palsy, particularly facial nerve palsy or meningitis, and fewer than 1% will have carditis, which typically presents with syncope. And then late disseminated or late disease is arthritis, almost always the knee. It's a mono or polyarticular arthritis. Neurologic disease, I've actually never seen late neurologic disease in a child. It's vanishingly rare. I probably shouldn't even have it on the slide. So how do you diagnose Lyme disease? Well, if you don't have the typical rash, and we'll get to that in a minute, people use serologic tests primarily, and it's a 2-tier procedure. First, a quantitative test, usually an enzyme-linked immunosorbent assay. And if that quantitative test is positive or equivocal, and only if it's positive or equivocal, you confirm the specificity of that test with a Western immunoblot. The original test used sonicated whole bacteria, laboratory strains so there's a lot of junk in there and a lot of cross-reactive antibodies, which is why you needed the confirmation with the Western blot. And a result should only be considered positive if you have both a positive or borderline quantitative test and a positive Western immunoblot. And the definition for that is 2 of 3 IgM bands or 5 of 10 IgG bands. What a band is, basically, they take this, for the Western blot, you take the sonicated bacteria, you put it on a gel and you put a charge across it, and the proteins migrate different distances depending on their molecular weight. Then you basically put the patient's serum on it, and if there are antibodies against those specific proteins, they stick, and you put a marker on that produces a band, and a band just means you have antibodies against that specific protein. However, misinterpretation of results are common. You'll see 1 or 2 positive bands. It'll say positive, and somebody sees the positive, and they interpret it as a positive test, when really it's a negative result. Now then there's a C6 ELISA, which measures antibody against a C6 peptide, which is a highly conserved lipoprotein. The hope was originally to replace the 2-tier test with this single ELISA. And the sensitivity of the C6 is very good, comparable to or better than the standard old wholesale ELISA, but the specificity is not as good as 2-tier testing. Recently, the FDA in the US approved a new 2-tiered algorithm in which Western blots are not used at all. The first tier test is an ELISA, and then the second tier test is a different ELISA. So you could use, for example, a C6 ELISA as the first and a wholesale ELISA as the second test. The advantages are it's easier to perform and less expensive. The results are available sooner. The subjective element inherent in interpreting blots would be eliminated because they're always a subjective element. And but the sensitivity and specificity of it is good, but it really needs, I think, wider usage to determine the true values. And I'm a little worried about the specificity. However, regardless, it won't have much impact on the main problem with serologic testing for Lyme disease. And we'll talk about that in a minute, which is testing people with a low prior probability of having Lyme disease. And we'll get to that. So this slide is just to remind me, this is from the CDC warning about testing for Lyme disease. And this is the second or third time they've done it. The FDA has put out warnings. There are a bunch of specialty laboratories, so-called Lyme disease specialty laboratories, which either have their own unapproved tests or they have unorthodox interpretations of regularly approved tests. And there's some labs that you can send a test to and you're guaranteed of a positive result. So you just have to be careful when you're interpreting those. All right, let's hit a couple myths about Lyme disease serology. First, there are many false negative antibody test results for Lyme disease. The sensitivity is poor. Well, that's true, but it's true in early Lyme. Remember, 80 to 90% or more of patients with Lyme disease have single or multiple erythema migrans. It turns out that the rash presents 7 to 14 days after infection, after the bite. Antibodies are not detectable for 3 or 4 weeks after. So it's true that the sensitivity is very poor in early disease. We don't recommend doing serologic tests. You should not test somebody with erythema migrans, but you don't need it because erythema migrans is such a characteristic finding. The sensitivity of these serologic tests for later disease, for example, arthritis, 100% of people will have a positive test result. But people have taken this poor sensitivity for early disease and said, well, the test is no good. That's wrong. People with symptoms for a month or more, you need to have a positive IgG result. There's no reason that they wouldn't if they have untreated Lyme disease. The next myth, early treatment with antimicrobials may lead to false negative serology. Well, that's true, but the reason is the treatment kills the bacteria and the antigenic stimulus to produce antibodies. You can't argue that a patient has ongoing symptoms from active infection but negative serology because of previous treatment. I mean, you can, and people do. It just doesn't make any sense. What else? IgM antibodies to B-Burgdorferi. So false positive results for IgM antibodies are extremely common. That's true, by the way, for any IgM test because there are multiple binding sites. So it's not just for Lyme disease. But in addition, the criteria for a positive Western blot is probably too liberal. You only need 2 of 3 bands to be positive. And the one study found the majority of adults referred to a Lyme clinic had false positive IgM Western blots as the reason for their referral. The other thing to remember is true positive result may persist even after successful treatment and cure of disease. People think, oh, the IgM is positive, it must be active or early disease. Absolutely not. It's well documented. You can, I mean, usually the IgM goes down or disappears, but many people have persistently positive IgM years later. The other thing to remember is a Western immunoblot does not equal truth. You cannot interpret it without an ELISA. If you just have a positive blot, even an IgG blot, uninterpretable. You need to show that the quantity is of antibodies is elevated. Then the blot means something. And false positive results are not uncommon, even with two-tier testing, as I'm going to show you in a minute. All right, so here's a quiz. What symptoms would make you want to test somebody for Lyme disease? Anybody? What? Arthritis? Arthritis is a sign, not a symptom. Walking through a forest, you're gonna, so everybody in Nova Scotia gets tested for Lyme disease if you go for a walk? Is that the? I'm sorry, changes in mood? I would not recommend it for changes in mood. What's that? Fatigue. The correct answer is none. There are no symptoms that are specific enough that the symptom alone justifies treating for Lyme disease. Do people with Lyme disease have headache, fever, arthralgia, fatigue? Sure they do. But so do lots of other people. And the probability that if all you have is fatigue, that it's Lyme disease causing it, are slim and none. Unless those symptoms are accompanied by specific signs, a facial nerve palsy, erythema migrans rash, frank arthritis, then definitely test for Lyme disease. Well, you don't test for Lyme disease if you have the rash because you just make the diagnosis. Who knows who this is? And no, it's not me as a young man. This is the Reverend Thomas Bayes, who lived in the 18th century, and he was a British cleric, but he also was interested in statistics and is famous for Bayes' theorem. And basically, tests for antibodies should not be used for screening or for proving negative result in someone with a low probability of Lyme disease. Only order when the prior probability or the pretest probability of Lyme disease is reasonably high. And what the pretest probability is, so this is a good the difference between a classical epidemiologist and a clinical epidemiologist like me. A classical epidemiologist will tell you the prior probability is just the incidence of Lyme disease in the population. Clinical epidemiologists say, yes, it's the incidence, but it's also taking into account all the other information you have. The epidemiologic history is somebody that lives in a high-rise apartment in downtown Halifax and never goes outside, or somebody who hikes in the woods. The epidemiologic history, the physical examination, and all tests that were done prior to that. That's the pretest probability. So and if you remember anything from this talk, this is what to remember. Let's suppose that we have a test for antibodies in which the sensitivity is 95% and the specificity is 90%. Pretty good test. I mean, there probably aren't too many tests that we do that are better than that. But let's suppose that the pretest probability of Lyme disease in the population we're testing is 1%. I can tell you if you test people who walk in the woods or have fatigue or arthralgia, I guarantee you the prior probability is way less than 1%. But let's just assume that these are all true and see what happens in a population of 10,000 people. So 1% have Lyme disease, so 100 people have Lyme disease. That means 9,900 don't. It's 95% sensitive, so 95 of those 100 people will have a positive test result. 5 will have a negative result. That leaves, of the 9,900 with no disease, it's 90% specific, so 8,910 will have a negative result. 990 will have a positive result. So there's 1,085 positive results, of which 91% are false positives. The positive predictive value is 9%. That's if it's 1%, okay, the prevalence. If it's 0.001%, which is much more likely, the positive predictive value is going to be vanishingly small. This, by the way, is true for any disease. This is not unique to Lyme disease. This is just Bayes' theorem. People don't think about this. It's not obvious to the lay public, and unfortunately, it's not obvious to most physicians, but it's critically important. And this, let me just show you. Here I changed the sense, I made the sensitivity 90% and the specificity 95%. And this is the prevalence or the prior probability. So it's 50%, then the positive predictive value. And 50% is what it would be in somebody with, say, a subacute arthritis in an endemic area. Then the positive predictive value of that test is 95%. If the prior probability is 5%, it's still 50%. But if it's 0.5%, it goes down to 8.3%. And if it's 0.05%, which is more like what it would be if you're testing people with nonspecific symptoms, it's less than 1%. The diagnostic accuracy for all of these is excellent. The diagnostic accuracy, which is not one of the indices that isn't often talked about, is just true positives and true negatives. What proportion are correctly classified? It's excellent. So to take a clinical situation, a patient with nonspecific vague symptoms, not likely to be Lyme disease, antibody to B. burgdorferi negative, diagnosis, not Lyme disease, antibody to B. burgdorferi positive, diagnosis, not Lyme disease. The moral of the story is don't order Lyme titers on those patients. Otherwise, you have to refer them to the Lyme disease clinic. You don't want that. Okay. So we already talked about this. It's rarely or if ever, the only manifestation, these nonspecific symptoms. You have to have objective signs. There's no evidence that chronic Lyme disease exists. I'm going to get back to this substantial scientific evidence that it does not. So there's some areas where ticks are common, actually parts of Nova Scotia nowadays. What's this? See that? This is an engorged adult deer tick. What do? What's that? Pull it out. Not a bad idea. Okay, so how to remove it? What do you do with the tick? Should you test the tick? Should you test the child? Should you prescribe chemo? So what you do is you take it out. You grab fine-tipped tweezers, grab it by as close to the skin as you can, and just pull it out. If there's a little bit of the head left, do not amputate. You can't tell you how many people come in with chopped up arms from it's not going to. And I can tell you, there's actually, this is true. There's in the Lancet many years ago, they published a letter from somebody saying in the northern hemisphere you should twist this way, and in the southern hemisphere you twist that way. It's true. Just pull it out. What do you do with the tick? Nothing. You just let it sit there. Yeah, discard it. Okay, who wants to test it? So the first thing you do is identify the tick, because if it's not a deer tick, you don't have to worry about all the things that deer ticks can transmit. You want the species, also the degree of engorgement, and we'll get to that. So shows you, I don't know how well the different life stages of the life cycle. This is the larva, which only has 6 legs, and then the nymph, which there's 3 stages, has 8 legs. So it's not an insect, it's an arachnid. It's related to spiders. This is an adult male, an adult female. If you forget, I have the life cycle on my tie. This red color is the normal color. This gives you an idea. This is an engorged nymphal stage deer tick next to the head of a pin. So you can see, and it's the nymph that's the one that's most likely to transmit it. The life cycle is that the adult tick the adult female takes the blood and converts it to eggs and lays the eggs. The eggs hatch in the early summer. The larvae feed. What they do is they quest. They get on a blade of grass or something, and they have sense organs under their legs. And if a warm-blooded host comes by, they glomp on, and they embed. It's not like a mosquito bite. It takes hours for them to embed their and feed. They actually secrete enzymes that break down human mediators of inflammation, so you don't feel it. They bradykinases and stuff like that. And then after that, it falls off, overwinters, probably under leaf litter, emerges as a nymph in the spring. That's the one that's most likely to transmit. because they're small, you can't see them, and people are out in tick-infested areas frequently in the spring and early summer. They feed once at each stage of the life cycle. By the way, Lyme disease is a zoonosis, so the spirochete lives in nature, is the normal reservoir. Humans are not normal reservoirs, but mostly in rodents, mice, chipmunks, small mammals. And each time they feed, they can become infected. They're not infected. The larvae are not infected. And then they become adults in the fall. And of course, they have a higher, well, I think I'll show you this. I can't remember exactly what I have. Okay, so this is an adult female deer tick. That red color is the normal color. This is an engorged adult female. You can see this black thing here is called the scutum, and you can actually estimate how long it's fed based on the scutum index, which is the diameter of the scutum compared to the whole body and weight. There are a bunch of nomograms because people tried it on animals and pulled them off and can estimate how much it fed. So they can get quite large, those adult deer ticks. This is a dog tick. You can see the silver scutum. If you see the silver, this is a female. The silver scutum is the giveaway that it's a dog tick, not a deer tick. And you can see this is an adult female deer tick and adult female dog tick. This is a Lone Star tick. This is the Lone Star in the middle. I don't know how much. Do you have many Lone Star ticks up here? Not much yet. Here's another tick identified. And if you need to, there are a bunch of websites where you can identify the ticks. This is a good one, tickencounter.org. So should you test the tick? The answer is no. Why not? Because the predictive value for infection of the human host of a positive test result is unknown. Infection may be associated with the concentration of Bieber-Dwarf ticks, which is not determined. In theory, a PCR can detect one spirochete. Maybe you need 100,000 per cc of tick juice. We don't know. So, and the sensitivity may vary with different assays and with degree of engorgement. So we don't recommend, so I agree, you get rid of the tick. Once you identify it, there's no reason to test it because it just causes undue anxiety. And should you test a child for antibodies? No, definitely not. Why not? Very low prior probability of Lyme disease. If they're positive at the time of the bite, it's undoubtedly from previous exposure, not from that one, or more likely a false positive result. The predictive value of a positive test result is poor. Should you prescribe chemoprophylaxis? Usually no, but sometimes. So why not? Very low prior probability of Lyme disease. It's only Lyme disease, not HIV. Relatively easy to diagnose, to treat, and to cure at any stage. So the proportion of infected ticks is related to the duration of attachment. The risk does not become substantial for infected nymphs for at least 36 to 48 hours, and for infected adult females until probably 72 hours. The reason for that is the spirochete lives in the gut of the tick, and it has to become engorged for it to migrate up to the salivary glands and be injected. So there was the best study is a randomized trial in Westchester County where they looked at persons 11 years of age or more who had removed the tick within the previous 72 hours. They gave them either 200 milligrams of doxy, a single double dose, or placebo. And what they found was in the doxy group, only 0.4% developed erythema migrans or Lyme disease. All of them developed erythema migrans. There were no asymptomatic seroconverters. And 3% of the placebo group developed Lyme disease. The protective efficacy was 87%. It was statistically significant, but a very wide confidence interval. They used, this is done by friends of mine, I still give them a hard time. I think the lower limit of the real confidence interval is about 1%. So it works, but who knows how well. But what they did find was in the placebo group, all of the people who got Lyme disease were bitten by nymphal stage ticks, and all 8 or 10% of the nymphs in which you could look at them and say, oh, that's engorged. It may not be fully engorged, but engorged, about 10% risk. Whereas if they were pulled off pretty quickly and they were flat or unfed, 0% risk even in the nymphs. None of the adult ticks transmitted Lyme disease, and none of the larvae. And if the nymph fed for more than 72 hours, about 25%, they were able to identify how long it fed in a certain number of the ticks. And of the 12 that they thought fed for 72 hours, 3 or 25% developed Lyme disease. That's the rate of infection of in nymphal ticks in Westchester County. So, but there was a high risk of minor adverse side effects. Everybody had to pull off the road and puke before they went home because so if you ever use it, give it with food. All infected patients developed erythema migrans, no asymptomatic seroconverters. Nearly 20% of them had another tick bite during the 6 weeks of follow-up. So you'll be giving a lot of prophylaxis. You can't extrapolate to amoxicillin for young children, although now, as I think I've shown maybe it's not. Oh yeah, it is here. Now it's okay to give doxy, certainly 1 dose of doxy, even to young kids for prophylaxis. But the results are not statistically robust. There's a wide confidence interval. The other thing is that ticks were identified by a medical entomologist. How many of you have a medical entomologist around to identify? It turns out there's studies of ticks sent by doctors for identification. 20% of them weren't even ticks. They were pieces of dirt, crab lice. Overall, still, the risk of Lyme disease, even in the untreated people, is only 1 to 3% in very highly endemic areas. So it's a very low risk. You know where to look. You just look at the site of the bite, and if the rash develops, then you treat them. By the way, sometimes, especially for adult tick bites, you can see a red mark at the site of the bite right then because it's a reaction to the tick saliva. If it's erythema migrans, it's going to keep getting bigger. Watchful waiting, I think, is still the most reasonable approach. But if you have an engorged nymphal stage tick that you're pretty sure has been on for 48 hours or more, it's reasonable to give 1 dose of doxycycline. It's a double dose. It's, I think, 4.4 milligrams per kilo, 1 dose. Okay, just to mention, there are a bunch of other co-infections that can be transmitted by this tick. Anaplasma phagocytophilum causes human granulocytic anaplasmosis. By the way, you can see these are the times to transmit. So 36 to 72 hours for Lyme disease. Anaplasma is less, 12 to 24 hours. Babesia, which I don't think you don't have Babesia up here yet. Do you ever see anaplasma either? Some anaplasma. It's pretty uncommon in children for some reason. They seem to be more resistant to it than adults. Babesia, 36 to 72 hours. Borrelia miyamotoi, which you probably do have up here. Have they tested the ticks up here for that? Yeah. Miyamotoi is a relapsing fever tick. It's the spirochete. It's the first relapsing fever Borrelia found that's transmitted by hard ticks, Ixodes ticks. Usually, relapsing fever is transmitted by a totally different species of ticks, soft ticks that feed quickly in 20 or 30 minutes. Typically, it's a disease that you see in people in cabins. The ticks infest cabins in the western states, but it's possible, and we're starting to see it, and it causes a relapsing fever type of disease. And Powassan virus, which is a flavivirus, it's a deer tick virus. It's a little like tick-borne encephalitis that they see in Central Europe. And that, in theory, can be transmitted in 15 minutes, and that's a little scary. Okay. Post-treatment Lyme disease syndrome. Patients who report nonspecific symptoms like fatigue, arthralgia, myalgia, problems with memory after documented Lyme disease. If the symptoms last less than 6 months, or if longer but don't cause functional disablement, it's called post-treatment Lyme disease symptoms. If the symptoms last for 6 months or more than 6 months and are disabling, it's called post-treatment Lyme disease symptom. It's unclear how common this is or whether it's more common after Lyme disease than in the general population. It's very difficult to determine this. I'm involved in a number of studies that have looked at it. Clinical trials of long-term antibiotic treatment, like 6 weeks of IV ceftriaxone, have been done in this group, and it's clear that these people are not suffering from antibiotic deficiency disease. These antimicrobials are not effective. It's not that these people don't get better. 40% of the people who got ceftriaxone got better, so did 40% of the people who got placebo. And there are substantial adverse side effects. I was just involved in a case in which a woman died from staphylococcal sepsis from the central line that got put in to treat her non-existent Lyme disease. So this slide, just look at the bottom part. I apologize here. This is actually a survey done in Canada of the sources of information. The blue is the sources of information that family practitioners use about Lyme disease, and the red is the sources of information of politicians and government health officials. And as you can see, the red people, 70% use social media, the internet. Physicians, a lot of the physicians get their information from academic medical literature, but this is newspapers, I think. So a lot of the policymakers and the politicians and the government officials get their information from the internet and public media, which I can tell you from having done interviews with umpteen reporters from, even Science and Nature magazine. Nobody wants to write about, oh, Lyme disease, no big deal. They want to tell you about the horrible suffering of people with Lyme disease. Oh, I forgot to mention the surgical procedure useful in routine management of patients with Lyme disease. Are you familiar with this? Does anybody do that? No? An internetectomy. It's hard to perform, but if you can do it, it's pretty effective. And I recommend it for all your patients with Lyme disease. So here's a real case. Jennifer was a 15-year-old girl, adopted, parents now divorced, A's and B's in school, diagnosed with strep throat 3 years earlier. She developed in August of 2014 insomnia, epigastric pain, diagnosed with gastric ulcers, treated with antibiotics. She developed shooting pains in her arms, legs, jaw, back, impaired short-term memory, night sweats, temperature intolerance, headaches, irregular menses, increased urinary rash in her upper eyelid and arm. I forgot to ask her about retrobulbar myxuralgia. You know that symptom? It's a great symptom. You ask, if you get somebody with a positive review of systems, you ask them if it hurts behind their eyes when they pee. The answer is yes. You can pretty much discount the history. Retrobulbar myxuralgia. So this lady had appointments with endocrinology, nephrology, neurology, ID, rheumatology, cardiology, missed school most days the past month. She had every diagnostic test known to man and some more. She saw a holistic medicine practitioner, suggested it might be Lyme disease. She came to see me. The child was completely normal on exam. Mom, who was a piece of work, did all the talking. This is not an unusual story. Less extreme cases are far more common in general pediatric practice, but we see this. This is the majority of new referrals to our PDID clinic in New Haven. So there's an alternate universe we're about to enter in which Lyme disease is something altogether different than what we've talked about before. And these, I don't know, these are testimonials of Olympic athletes who overcame chronic Lyme disease. Mitt Romney thought he was going to win the election years ago by flooding the Virginia suburbs outside of DC with flyers about how he was going to fight Lyme disease, and he thought that would win him the electors in Virginia. I get a lot of emails. This is one I got. Notice this is from Redneck 5. I'm still waiting to hear from Rednecks 1 through 4. Sir, your public comments that say there's no such thing as Lyme disease is a lie. To say such a thing is your Yale pansy ass could not handle it. If there's no such thing as chronic Lyme disease, why don't you inject in your body and see if you're right? Please respond. So what is chronic Lyme disease? What's the definition? It turns out there is none. This kind of complicates studies, right? Basically, The definition is essentially that someone, often a Lyme literate doctor, says the patient has it. Often patients themselves conclude they have chronic Lyme disease and seek a provider who will confirm and treat them. ILADS, which is the International Lyme and Associated Diseases Society, which is the alternative to Lyme advocates and both patients and physicians, Lyme literate physicians, come up with these definitions, and basically it's inclusive of persistent symptoms: fatigue, cognitive dysfunction, headaches. Your person walking, maybe walking through the woods will do it too. Here's the symptoms of Lyme disease: fatigue, low-grade fevers, irritability, depression, back pain, blurred vision, poor concentration, lightheadedness, dizziness. That's all you need for chronic. Here's another one. Do you have unexplained symptoms? Have you had any of the following? It lists every symptom known to man. This is from a group, a Lyme support group in Colorado. There are no ticks that contain Borrelia burgdorferi in Colorado. This is a map that shows you the dark line, the dark spots are incidence of Lyme disease, and the kind of shaded areas are where it's beginning to expand. And you can see that it has been expanding, but it's expanding in the, proximate to the other areas. This is a map of where the Lyme disease support groups are. Lyme disease support groups. I'm not sure I need to say much more. So there's something called medically unexplained symptoms, which are physical symptoms with little or no basis to attribute to an underlying medical disease. When a medical condition does exist, the symptom inconsistent with or out of proportion to the illness. People with medically unexplained symptoms are not necessarily normal. Many people exhibit them, but seldom seek care. Become a problem when they lead to frequent healthcare seeking for fear of non-existent physical illness. Among patients seeking medical care, probably 50% have medically unexplained symptoms. For the large majority with mild symptoms, treatment is simple reassurance, symptomatic medications, and a good provider-patient relationship. Laboratory tests should be avoided. These are often stress-related. I mean, my arm hurts, and it hurts worse when I get into a fight with my wife. Laboratory tests should be avoided in these patients with short-term, often stress-related symptoms that typically resolve in a week or two. But more troublesome are the remaining small minority whose symptoms are chronic and more severe and may result in really severe physical and psychological disability. And people don't really appreciate how profound that disability can be. Each subspecialty has its own. We have chronic Lyme disease in ID. We used to have, some of you are old enough to remember chronic mono. We used to get called 5 times a week about chronic mononucleosis. Gone, it's completely gone. I haven't heard that term in years. It's all the same symptoms. It's now chronic Lyme disease. Rheumatology, and chronic fatigue syndrome. Rheumatology is fibromyalgia, chronic pain syndromes, GI is irritable bowel syndrome. There are studies where people with the same exact symptoms, if you show up at a GI clinic, you've got irritable bowel syndrome. If you show up at a rheumatologist, it's fibromyalgia. Each subspecialty has its own: chronic cough or pulmonary, chronic headaches. Every time I put this slide up, at the end, another subspecialist runs up to me and says, "You got to add this to that list." Psychosocial factors propel and amplify the symptoms: the belief that one has a serious disease, the expectation that one's condition is likely to worsen, sometimes a sick role, litigation, compensation, and often the portrayal of the condition as catastrophic and disabling. Patients are often strongly assertive. They have a sense of embattled advocacy for their ideologic suppositions, and they devalue and dismiss medical authority and evidence that conflicts with their beliefs. It's complicated by sensationalized coverage in the media, the internet. If you, actually, this is old. If you Google chronic Lyme disease, you get well more than 5 million hits. There's a profound suspicion of medical expertise and of physicians, and frankly, a clinical approach that overemphasizes the biomedical and ignores psychosocial factors. Here's some unconventional treatments that are offered to these patients. Everybody's familiar with prolonged. When I say prolonged, I mean years of treatment with antimicrobials. Stem cell transplant. I can tell you a clinic that'll give you a stem cell transplant for chronic Lyme disease. Heavy metal therapy, there have been deaths from treatment with bismuth. There's a guy in Kansas in jail for that. IVIG, my favorite, anal or vaginal infusion of ozone. There's a clinic in Bali if you want to, that will do that for you. There's actually the woman I talked about, there's something they call it autohemotherapy, I think is what they call it. That woman who died from staph sepsis had a central line put in, and 3 times a week would have blood taken out, ozone bubbled through it, and then have the blood put back in. Autohemotherapy. Hyperbaric oxygen, Rife machines, you name it. So this, I'll go through these slides quickly so we can have some questions, but basically the prevalence of chronic widespread pain in the population is great, and it's not limited to the United States. 15% in these studies. Actually, there was a recent study in the US, 20% of people complain of chronic pain, but it's you know, even in Sweden, it's 15%. This is the percentage of adults who felt very tired or exhausted in the past 3 months. What that means is this is a survey they do every year, and 15% of women and 10% of men feel either very tired or exhausted every day or most days in the last 3 months. So fatigue is a relatively common symptom. Now, in truth, doctors are part of the problem. We're very good at treating diseases and diagnoses. We're poor at managing symptoms without a diagnosis. There's a large literature on medically unexplained symptoms and functional somatic syndromes, and saying it's not Lyme disease rarely solves the problem for these patients. What they really hear is there's a stigma associated with these medically unexplained symptoms, and what they hear you say is it's all in your head. There's also qualitative studies of doctors that indicate that they may have negative feelings about such patients that influence their management because they don't, probably in part because they haven't been trained and don't feel competent to manage it, unless you're a counselor, a psychiatrist or something, or like me, you do psycho ID. Although I can tell you, you can find me on the Lyme Disease Hall of Shame on the internet, and I won't go into it. I've been picketed on 2 continents. I didn't see any pickets here. Medically unexplained symptoms are common and should be treated seriously. Patients really are, and most of these patients are not making it up. They're suffering, and they're seeking affirmation, sympathy, and concern. The problem is they go to umpteen subspecialists who are the ones least likely to develop a long-term therapeutic relationship with them, which is what they really need. Explanations should integrate psychological and biologic factors and provide patients with a model for managing the problem. Associated organic pathology is rare and rarely missed. Psychological problems are common and often missed. Depression and/or anxiety are often present. It's a paradigm for many other functional symptoms. What do you do about it? It's not easy. Really, I think the trick is to focus on the symptoms, not the diagnosis. You have to affirm their symptoms, say, kind of convince them that they don't have some horrible underlying something that's going to do them in. And a trusting relationship. Exercise is critically important, counseling, improving sleep, and in some instances, low-dose medications that can help sleep. Get them, the big thing is get them back to work, school, up and going. Primary care docs really need to be trained in how to manage patients with medically unexplained symptoms that do not need to be referred. More research needs to be done. I'm going to stop here and see if there are questions.
We have about 10 minutes for questions, and Denise has a microphone. If you'll just wait for that. Dr. Isakutz, the floor is yours.
Thank you very much. That was very interesting and quite informative in terms of both these patients, which both applies in immunologist as well as immunology. We see two often. My question is, why is there no PCR for this?
There is PCR. Actually, I took the slide out to make it shorter. So the problem with PCR is that everybody knows what PCR is, right? Polymerase chain reaction, where in theory you detect, you know, the DNA of the spirochete. You could detect, in theory, one spirochete there. So the problem is that the concentrations of spirochete are very low. So if you do, for example, an LP, the sensitivity is extremely poor because there are very few. You cannot grow in PCR is about 70% sensitive for arthritis and if you do tap a joint, for example, but 100% of them have antibodies, so you don't need it. It's probably only useful in somebody who has recurrent arthritis that you thought was Lyme disease and you're treating, and you need to confirm that it really was Lyme disease. The other problem with PCR is if you do a PCR, it doesn't mean that it's live organisms, because it probably can remain positive for a month or more, many months after successful cure of disease. You can do it. People do it on biopsies, and you can do PCR, and you can do it in blood if you get a large volume. If you get 10 cc's of blood, sometimes you can do it on that, or people often culture it. The problem is culture, you need special media, and it takes 6 weeks for it to grow, and so you don't get an answer. So you don't really need it. The issue is really, how do you prove in the negative? And the answer is you can't. Really what you're asking is, these patients that you think, how do you prove to these patients that have chronic symptoms that it's not Lyme disease? There is no test that's going to do that for you, unfortunately.
Yes, Alice, Dr. Chania.
Before I retired from pediatric practice, I was collecting cohort of patients presenting with medically unexplained symptom, and I'm so happy to listen to your lecture. And in fact, one of the problems is the unidentified psychosis. So
oh yeah.
Among these patients. So it's a very complex problem. But now I can add one more presentation as Lyme disease.
Good.
Thank you very much.
Dr. Stringer right here. And Elizabeth, do you mind just commenting for all of us just how often your division might get referrals for people with MUS in this context? That would be interesting to know.
So I'm a pediatric rheumatologist, and I think just like every specialty, we all have our version of it, and chronic Lyme is sort of permeating into the concerns of those families. But I think we try to take the same approach as you described in terms of trying to treat the symptoms and try not to focus on having diagnosis. We are, of course, seeing lots of Lyme arthritis as well. So it's a sort of disease that we're seeing, which is interesting to us because when I first started 10 years ago, we were having a handful of cases, and now we're seeing many more and many sorts of different versions of presentations. My question is that, sometimes I get the family that, I know it's not Lyme disease, and they really, 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 really want to test for it, and I know it's going to be negative. And obviously your advice would be not to test for it. Sometimes I feel that negative test for families to have reasonable understanding of Lyme can be helpful, because they are bombarded by everything else that people tell them on the internet. So how do you have that conversation if you always not test for it?
So the question is, when you know it's not Lyme disease, but the family wants to be tested, is there a way to do it? And the answer is yes. I mean, I agree with you. I don't always not test, but I think what you have to do is say, look, there are lots of false positive results. If you have a reasonable family, if the result is positive, I still don't think it's Lyme disease. It could be that you were exposed 10 years in the past and it has nothing to do with it. There are a lot of false positive results, but let's do it. We'll send it. If it's negative, you'll feel better. If it's, you have to have that discussion with them, and it's a mixed message if you say, I know it's not, I don't believe it, even if it comes back positive. Well, why are you doing it? So I understand the dilemma, and sometimes, but that's the way I would approach it.
Dr. Huber, also from rheumatology.
At some risk of going down a different rabbit hole, to comment on congenital Lyme. which we see probably one a year or so, who are very strongly convinced.
There's never been a documented case of congenital Lyme disease. It doesn't exist.
Okay. Over in the corner, right in the corner.
So I was wondering if you have any thoughts about the subspecialty general approach to medically undiagnosed symptoms when you don't have that long-term relationship, when you know beforehand, when you see the patient, when you see the consult, that there is no indication or suspicion for a for example, biological injury, which could be a diagnosis. I wonder if the better approach is, or an idea is to have that discussion again with the primary care provider to say, hey, we probably are not doing any good. If anything, we may be doing harm by having them see more multiple subspecialties. I wonder if you have thoughts.
So I think the question is, how do you prevent the patients from coming to you in the first place if you're not going to do anything for them? And sure, if you can have, I mean, it's a good idea to have if you can convince the referring doc not to refer or to refer to somebody else. Sometimes the patients need you to, they need to go to the Mecca and have the blessing that that's not what it is. But so I think you just have to try to show sympathy and empathy for that they really are suffering and that you believe they have the problem. You're convinced that it isn't cancer, it isn't some serious infection. It's been going on for 9 months, and the patient would have lost weight, and it would have been obvious. So let's try to figure out how to focus on the symptoms. And I mean, ideally, there are some places that have clinics and docs who specialize in chronic fatigue syndrome, and that's the ideal thing. Get him to hire somebody to do that for you.
Hi, just a layperson here, and maybe this is a stupid question, but is there any evidence that people can just clear Lyme disease on their own without?
So the question is, can you have Lyme disease and get better without treatment? And the answer is absolutely yes. Very well documented, no question about it. Happens all the time. In fact, the original cases of Lyme arthritis, so it's called Lyme disease because the original cases were described in children in Lyme, Connecticut. And of course, they didn't know what caused it or how to treat it. And they did studies, 20, 30 years later of these 45 or so children who never got treated with antibiotics. And what happened to them is they had recurrent episodes of arthritis every year, but each year there were fewer and fewer episodes. And by 7 years, they had no more arthritic episode. And long-term follow-up, I think there were 2 or 3 of them that had some, like one had an ocular problem that might have been related to Lyme. There were, but the 90% of them or more were fine, even though they were never treated.
Yes, last question.
Are there topical like repellents that find effective?
Yeah. So the question is tick repellents. So yes, DEET works. You want to get 30% or more. You put it on your skin. For children, you don't want it on their face or hands. The problem is you have to apply it with some frequency. The other thing you can use is permethrin and put that on your clothes. And that kills ticks on contact. You don't want that on your skin because I think it breaks down very rapidly on your skin. But you can put that on your clothes. But the answer is yes.
Well, I'd like to thank Dr. Shapiro for coming today. And this case really illustrates, the topic illustrates the art and the science of medicine. Human beings, we are rational, we have emotions, and skilled physicians will know the importance of a therapeutic relationship and a trusting relationship to work through some of these sometimes nuanced and difficult problems. So thank you for coming today.
My pleasure. Thank you.
Shapiro, Kevin Gordon. I'm
Hi.
a pediatric neurologist. I have a short question,
Sure.
a long question.
Okay.
This is a recent